Okay, I'd like to welcome everybody to Pediatric Grand Rounds. I'm going to turn it over to our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our speaker for today.
Hi, everybody. Welcome. It's a great pleasure to introduce our speaker, Dr. Edison Cuneo, who is going to talk to us about the intersection of medical and social complexity. Dr. Cuneo is an assistant professor in pediatric gastroenterology, hepatology, and nutrition at UCSF and a native of San Francisco. Her research focuses on medical traumatic stress in pediatric onset chronic disease, including diseases such as cystic fibrosis, inflammatory bowel disease, and chronic pancreatitis. She's a recipient of the Cystic Fibrosis Foundation Harry Swakman Clinical Investigator Award for her project Generating CF Criteria and a Survey Tool for Medical Traumatic Stress. Ultimately, she seeks to design and implement healthcare system level changes that prevent, screen for, and treat pediatric medical traumatic stress. She's an expert in pediatric pancreatic disease and serves as the pediatric gastroenterology provider in our Pediatric Cystic Fibrosis Center. Additionally, she's part of the core design team for the UCSF Child and Adolescent Chronic Illness Center, where she co-leads the clinical care design and delivery work group, engaging stakeholders in the mission to design a center that cultivates a lifetime of wellness for children and adolescents living with chronic illness. And we always ask our Grand Round speakers to just give us a little bit of insight on how they became passionate about what they're doing. And Dr. Cuneo told us that through her pediatrics training and GI fellowship, she was drawn to the disease processes that stood at the intersection of medical and social complexity. The more time she spent at the bedside, the more she wanted to engage with the all-encompassing puzzle of chronic illness and pediatric medical traumatic stress, seeking to understand the causes and implications of medical trauma and how providers could, in fact, do no harm. With that, I'm handing it over to Dr. Cuneo.
Thank you so much. And thank you, Dr. Hirsch, and to the department for having me today. I'm really excited to be here to discuss medical traumatic stress and the challenging path we have towards doing no harm in pediatric onset chronic illnesses. I have no conflicts of interest. My work is funded through the Cystic Fibrosis Foundation, and some of the early work that I present today was funded through my GI fellowship grants through the foundation. And additionally, I've received some mentorship through the Collaborative Alliance for Pancreatic Education and Research. Our learning objectives today are to become familiar with key concepts of medical traumatic stress, to understand the unique triggers, manifestations, and functional impairments of medical traumatic stress in pediatric onset chronic illnesses, and to recognize some of the first steps that you can take towards integrating trauma-informed and trauma-minimizing care into your practice. It's a tall order, but we'll do the best that we can. We'll divide things into 3 sections. First, looking at pediatric medical traumatic stress definitions, frameworks, and getting an understanding of what is known. Then looking in more detail at the chronic illness experience, thinking about what's different. I'll share some of my early research in chronic GI disorders, as well as a recent qualitative investigation into the patient experience of medical traumatic stress. And we'll think about where we go from here, reviewing some of the trauma-informed care principles, and the application of these principles to the medical setting, as well as thinking about some resources you should know and next steps for research. But before we dive into everything, I want to invite you, if you're in a place and space where you can, to take a moment to consider a time when you witnessed a pediatric patient in distress. What did you do? What did the people around you do? And how did that moment even come to be? I'm going to give a full 30-second pause. Thank you. Thank you for having that moment of vulnerability. As you know, as healthcare workers, helping is at the core of our beings. So it takes courage and it takes vulnerability to admit that sometimes in the process of pursuing the health for our patients, harm and even trauma can occur. I'll quickly share my experience. I was a fellow in pediatric gastroenterology in my first year. I was in the endoscopy suite going about my usual business, and an 8-year-old girl rolled into the room for her procedure. I'd actually cared for her many times before, so we had an established relationship. She carried multiple chronic GI diagnoses. And the moment that she entered the room, she launched into an elaborate protest. She was whining and pleading, and it escalated to screaming. "I know what you're trying to do to me," she announced when she was wrestling her way to the door. Her parents were there, and a child life specialist was there, and a pediatric anesthesiologist who had years of experience working with these scared children was there. But even despite all this, all these measures, there was sheer terror in this girl's eyes. It wasn't her first rodeo, and it wouldn't be her last. It was in that moment that it became crystal clear to me that in the pursuit of her health, there was not just pain or anxiety, but that we were causing trauma. It's a little bit uncomfortable to hear, but it's true. And only by bringing light to these experiences can we start the process of growing towards a system that truly does not harm pediatric patients with chronic illnesses. So today, if your circumstances allow it, I encourage you to move out of your comfort zone into a place of learning and growth. One quick disclaimer is that while I work closely with lots of mental health providers, I am not one. So some of you are and many of you aren't. But please take advantage of the mental health providers who are around you within UCSF and beyond. They're an incredible resource, and I encourage you to collaborate with them. So without further ado, let's dive in a little bit about medical traumatic stress. So what is medical trauma, and how does somebody even become traumatized? Well, first, the person has to undergo some kind of a threat. We call these potentially traumatic events or illness-related experiences. In medical trauma, these are discrete external events such as an invasive treatment experience, an injury, a procedure, or receiving bad news like a severe diagnosis. In some patients, this event is going to trigger a pattern of abnormal physiological and psychological responses in their brain. Based on the adult PTSD literature, we think that these responses can be captured in part, at least, by some of the domains, by some of the symptom domains of PTSD. These are arousal, like abnormal startle reflexes, and disproportionate autonomic responses to small threats, intrusion, like flashbacks and re-experiencing, negative mood, including depressive symptoms, and avoidance of potential triggers. When we think about what mediates the brain's tendency to form these reactions, we have to invoke some of the foundational models of social medicine. We know that every patient comes into a circumstance with a set of biological, social, and psychological connections, and then that there's going to be further influence from external factors like the patient's familial support system, like the medical center support and community level factors. And together, these fluctuating influences are going to determine if a potentially traumatic event will in fact become traumatic. It is notable that there are some models that account for the idea of somatic threat, that a patient's interpretation of their illness itself is life-threatening and can trigger these same kinds of responses. That comes mostly from the adult literature. So put a little bit differently, the National Child Traumatic Stress Network defines pediatric medical traumatic stress as a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. There's two important related concepts that I want to just bring up here. So one is the idea of post-traumatic stress symptoms. These are the symptoms in those 4 symptom domains that we just discussed. And then the other is the idea of post-traumatic stress disorder, which is defined by more stringent DSM criteria, which many of you are familiar with. Only a subset of those with post-traumatic stress symptoms will qualify as having post-traumatic stress disorder. And when we think about our patients that we see in clinic, we can think of the Venn diagram as looking somewhat like this. There are patients with pediatric medical traumatic stress who have symptoms that fall into the post-traumatic stress symptoms categories. There are patients who have post-traumatic stress symptoms from other non-medical events. And then there's a subset who meet those more stringent PTSD criteria. There are a few challenges that get highlighted here. One is that the pediatric medical traumatic stress responses outside of these classic post-traumatic stress symptom areas are loosely defined. And secondly, the available resources to measure pediatric medical traumatic stress are drawn from these post-traumatic stress symptom measures and PTSD measures. So they're really not tailored to the specific experience of pediatric medical traumatic stress. There is a predominant theoretical framework that's used for medical traumatic stress. This is called the integrative trajectory model. It was developed by Anne Kazak, who studied this topic extensively in children with cancer. She described 3 phases: the peri-trauma phase, the acute medical care phase, and the ongoing care or discharge from care phase. And she highlighted the importance of the subjective response of the patient to the events. So those responses that the patient have actually has a reciprocal relationship with these moments in care. She noted that parents, patients, caregivers, and siblings can all experience this distress. It's not isolated just to patients. And she noted sort of what these trajectories may look like. So she cited that some patients, some patients may be more resilient, that they may have this tendency to have some distress initially during the peri-trauma phase, and then to be able to come back down. And then she noted that other patients may have continued high levels of distress that over time escalate, become chronic, or they recover from. The bulk of pediatric medical traumatic stress data focuses on children with pediatric injuries, such as car accidents, and cancer patients. In recent years, the field has been widening and has increasing inclusion of other diagnoses. We note across the board, as seen here in this review article by Price et al., that there are these hugely widening ranges for estimates of pediatric medical traumatic stress prevalence. Well, why might that be? It's because the direct comparison of studies that look at this is very limited. There's marked heterogeneity in the measures that people are using, that the potentially medical traumatic event that is being referenced by the measurement is different. The timing from the perceived traumatic event to the time when people are measured are different. So it makes systematic understanding of this somewhat challenging. There was a recent meta-analysis done by Pinquart and et al. In 2021 that showed that there was an 11.5% average PTSD, again, those more stringent criteria, in children with chronic physical illnesses. There are several key associations between PMTS and important predictors and outcomes. A recent topical review of medical trauma in early childhood by DeYoung et al. Highlighted the evidence around child-specific factors, including temperament like negative affectivity and pre-existing difficulties with externalizing and internalizing. Family risk factors are well established, including especially parent psychological distress as being a predictor of pediatric medical traumatic stress. And recently, Ben Airy et al. Conducted a prospective study of 235 pediatric surgical patients and noted that perceived low family social support using the psychosocial assessment tool was associated with PMTS. One unsettled area of ongoing exploration is the role of illness-specific factors in the development of PMTS. So studies on acute asthma exacerbations, injury, burns, and organ transplantation do seem to show an association between illness severity and illness factors with PMTS. However, this stands in contrast to the literature on several acute medical traumas and much of the early literature in cancer as well that supported psychosocial factors as opposed to medical factors as primary drivers. So turning to the downstream effects of PMTS, the literature supports an association between it and lower quality of life, especially in solid organ transplants and in patients with road traffic accidents. There has been some recent work raising concern for association between PMTS and opioid use. And there's been a fair amount of work done in liver transplant looking at medical trauma and medication adherence, indicating concern for association there. So you can see how this is leading to us raising ample concern about our patients with pediatric onset chronic illnesses. So what is a pediatric onset chronic illness? Well, definitions certainly vary. In the past, there had been checklists that were used to define who has one and who doesn't. But Stein et al. Have a nice definition that I tend to use. So they define ongoing health conditions as disorders that have a biologic, physiologic, or cognitive basis, and have lasted or are virtually certain to last at least a year, so have a certain duration needed. And then they focus, instead of the exact diagnosis, on the sequelae, the impact on the patient. So they have to have one or more of the following sequelae: limiting function, needing dependency in order to minimize the limitation of function, such as need for medications or special diet, and then the need for special medical care or related services. Similar to medical traumatic stress, the variation in definitions here has made a singular estimate of prevalence be quite challenging. So we see wide variations. For example, the CDC estimates that at least 40% of school-aged children and adolescents have at least one chronic health condition. They're basing that on the 2018 National Survey of Children's Health. But regardless, we know that these illnesses are increasing in prevalence, and there are key commonalities in these patients to their illness-related experiences, including frequent medical events, invasive monitoring tests, and arduous medical regimens, unpredictable hospitalizations, and poor long-term health outcomes. So when I was starting to think about applying the data from other studied populations to my patients with pediatric onset GI illnesses, I saw that there were several important commonalities: the prolonged hospitalizations, the medical procedures, but there were also marked differences that made the patient journey quite different. When patients showed up to me in GI clinic, they often have an indolent onset of disease. They've been dealing with this for months, even years, before arriving at my floor. And this is and have had medical experiences associated with that. This is very different than the abrupt onset of pediatric injury, and honestly of some cancer diagnoses as well. My patients were also experiencing very unpredictable disease courses. They required lifelong medical encounters, and they needed burdensome lifelong preventative regimens. Now, everybody is a little bit biased about how important their own organ system is, but to me, GI disease really impacts your daily life. And so that was a reason to think that maybe medical trauma looked different in these patients. And when we think about applying what we know about medical traumatic stress to children with chronic illness, we definitely have reason to worry. So we know that recurrent exposure to trauma across the developmental spectrum is associated with toxic stress. It can change the developmental trajectory, our physiology, our DNA, and that it has lasting impacts on all domains of psychosocial functioning. And we know that by the pioneering work by Folletti et al. And others in the adverse childhood experiences work, that these associations are dose dependent. And our patients with chronic illness are getting recurrent, potentially traumatic events. So what might the impact be of recurrent medical trauma on patients with pediatric onset chronic illnesses? I really wish I could answer that question for you today, but we are not quite there yet. So let's start where I had to start. So I sought in my fellowship to explore the potentially traumatic events and PMTS symptoms in 3 populations of children and adolescents with incurable chronic illnesses that were impacting the GI system. We looked at inflammatory bowel disease, acute, recurrent, and chronic pancreatitis, as well as cystic fibrosis. And we sought to look at the prevalence in our patients, the risk factors, and explore some of the potential consequences of medical trauma. So I went about designing and implementing this as a cross-sectional study due to several limitations. And it started out as a single center study here at UCSF, and then we expanded to a second site at Cincinnati Children's Hospital. We recruited patients from August 2018 to May 2020, and we had both patients and their parents participating. You can see here our inclusion and exclusion criteria. We involved patients that were 7 to 21 years old who spoke and wrote in English and or Spanish. And they needed to have 24 months of available medical records and at least 2 visits with providers at the research institution. We defined pediatric medical traumatic stress as exposure to a potentially traumatic medical event and scoring as symptomatic in at least one symptom domain. Our measure was the UCLA PTSD Reaction Index, which is a validated self-administered survey. It has 31 items that look at symptoms in the preceding month that are scored on a Likert scale. And then there's a standardized scoring system for each post-traumatic stress symptom domain. We wanted to explore some potential risk factors. Unfortunately, our ability to do this was somewhat limited both by our sample size as well as what information we had available to us at both institutions. But here you can see what we were able to look at: demographic factors, markers of illness burden and types of medical encounters, mental and physical health comorbidities. We were also able to look at functioning and the need for additional support through the medical system. Of note, parent PTSD and child quality of life were selected as additional psychosocial factors that we wanted to explore in more detail. So at the time of study participation, parents completed the Impact of Events Scale Revised, and children completed the PROMIS Global Health Pediatric Questionnaire. So we had 132 patients. You can note that we had a good balance of gender, race, and insurance status. There were marked medical and mental health comorbidities, with 42% of the population having a medical comorbidity and 30% having a mental health comorbidity. These patients were having frequent contact with the health system. And when we look at this, we saw that most patients with our illnesses in our cohort were being exposed to potentially traumatic events. So 69% of them endorsed either having a time where they or their parent thought that they may die, or having a very scary treatment experience. Over a third had symptoms of medical traumatic stress, and about 15% met the more stringent criteria for likely PTSD. When we compare these findings to other studies of pediatric medical traumatic stress in non-cancer pediatric onset chronic illnesses that use the same measure, we noted similar or even a little bit lower prevalence of the medical potentially traumatic events and of pediatric medical traumatic stress. Compared to those patients with scary medical experiences only, participants with any life threat had more than triple the odds of meeting PMTS criteria. This is interesting because with recent advances in medical treatment, these chronic diseases actually pose a relatively low threat of childhood mortality. Still, the children in our cohort were perceiving life threat. And this perception of life threat was actually the least common in the most life-limiting disease, cystic fibrosis. And it was observed in a similar percentage between those who were and were not exposed to intensive care admissions, despite the known association between intensive care and PMTS. Further investigation is needed. Excuse me, one moment. I'm just recovering from a non-COVID cold, so I apologize about that. Further investigation is really required to understand why these patients with chronic but rarely life-limiting disease are perceiving life threat. All right, I got my cough drop going, guys. So we need to understand why these patients who have chronic but rarely life-limiting disease are perceiving life threat, and if there's some kind of a gap between the patient and the provider appraisal of illness severity. This has been documented in other populations, and I think we wonder if that gap may represent a potentially modifiable pediatric medical traumatic stress risk factor. Looking across disease groups, symptoms of intrusion and arousal were most present. Figure 2b illustrates the marked overlap between symptom types among patients with PMTS. This is important because we know that there is some overlap between arousal symptoms and anxiety, and negative mood symptoms and depression. Nationally, in both general pediatrics and subspecialty clinics, there has been a movement towards general mental health screening for anxiety and depression. However, our results suggest that these screeners might be missing some individuals, especially those with intrusion or avoidance symptoms. Excuse me. Additionally, the potential role of medical PTEs as a driver for these increased risks of anxiety and depression in patients with pediatric onset chronic illnesses remains underexplored. So turning to our exploration of risk factors, in univariate analysis, children with government-sponsored insurance, acute recurrent and chronic pancreatitis, medical comorbidities, increased medical exposure over the last 2 years, and parent PTSD were significantly more likely to meet PMTS criteria. Variables with a p-value of less than 1 in univariate analysis were included in a backwards stepwise logistical regression to generate a final multivariate exploratory model of PMTS risk factors, which indicated that parental PTSD, emergency room department visits, high home medication burdens, and intensive care stays in the last 2 years warranted further exploration in the future as potential risk factors for medical traumatic stress in those with chronic illness. An exploratory analysis meeting criteria for PMTS was associated with increased odds of markers of impaired psychosocial functioning across the board. Specifically, children reporting PMTS missed more school days, had lower quality of life scores, their parents were missing more work days, and there was an association with increased odds of home opioid use. So our work extends the literature on PMTS into 3 populations of children with incurable chronic diseases that impact the gastrointestinal tract. And we observed that a substantial proportion of our cohort had were being exposed to medical potentially traumatic events and were experiencing symptoms of medical traumatic stress. Prospective longitudinal studies of pediatric medical traumatic stress in pediatric onset chronic illness populations are really needed to elucidate these risk factors and downstream effects of pediatric onset chronic illness. So I was hoping to march forward with my research after this, but as I dove deeper and deeper into this, I realized that I was not here in this risk factor analysis stage, but we actually needed to take a step back in order to move forward. Because in order to design symptoms that prevent and treat medical trauma, we needed some measurement for systematic study. We needed clear definitions to understand what the patient experience was like, and we needed tools that were specifically capturing the patient's experiences. So in recognition of this need for definition and measurement tools, I developed a research proposal with the hopes of better understanding pediatric medical traumatic stress and chronic illness through a stakeholder engaged and mixed methods approach using cystic fibrosis as a test population. My goal here was really to harness the perspectives of families and care teams and patients themselves to really understand what their experience was of trauma, generate some criteria, and then utilize that to develop a instrument that was specific to their experiences. I've been fortunate to have this research funded by the CF Foundation through my Career Development Award with them, and I can share with you today the results of the first aim here. So in this qualitative study, we engaged people with CF, family members of people with CF, and CF care teams in semi-structured interviews and focus groups with the aim of characterizing the illness-related experiences that they perceive to be traumatic, the manifestations and symptoms that they perceive to have from their trauma, and the functional impairments that they saw as being derived from those symptoms. It was a national study of stakeholders who responded to our outreach efforts, and we sought to really capture a wide range of perspectives. Our analysis methodology employed Dettering and Waters' flexible coding for in-depth interviews, which is a 3-step process that seeks to ensure that all data are evenly considered. It involves indexing the transcripts and developing analytic codes that are then applied across interviews. And then there's a constructive process of theory development and refinement. So we had a total of 51 participants. You can see that there were 31 patients with CF and family members of people with CF of varying ages, and 20 cystic fibrosis care team members who were involved. There were a broad range of stakeholder types. There was extensive experience with CF, both personal experience on the ends of the patients and those with the caregivers, as well as on the cystic fibrosis care team members. We obtained a national perspective, and despite some early challenges in obtaining a diverse sample, we were ultimately able to recruit a sample that more closely represented the population in the National CF Registry through some targeted efforts. It is notable that cystic fibrosis has a higher prevalence in Caucasian populations, however. And then one thing to note was that 61% of these patients would have scored negative on a in-clinic adverse childhood events screener. We had a balance of insurance types, but a tendency to have more highly educated individuals, with 81% having some college or an advanced degree. So this is just an overview of the thematic analysis, and I'll go into the pieces in more detail. So traumatic illness related experiences, we heard about a lot of them. They fell into these sub-themes, which we were able to summarize in the key themes of bodily harm, threats to agency, and shifts in identity. In terms of medical traumatic stress symptoms, we found that they did fall within the DSM symptom categories. However, there were important specific manifestations of these symptoms that we needed to address. And then there were broad functional impairments. However, but amongst these were important health management impairments that we will discuss further. So as we started to talk to people about illness-related experiences that they report as subjectively traumatic, we heard the stories that you might expect about painful procedures, terrifying and confusing ICU stays, what they've perceived as gaps in communication around difficult diagnoses that led to feelings of helplessness and confusion. But we also heard more. We heard about what was happening at home and outside of the medical care setting as well. And we saw that a single person can undergo the same type of procedure or the same type of event on multiple occasions, but only one of those instances may be thought of as traumatic. Similarly, multiple individuals can undergo the same procedure with only some of them identifying that procedure as traumatic. So I commonly field questions from colleagues about what procedure is most traumatic, or focused attention towards just blood draws or just radiology experiences, etc. What we really saw here is that it had less to do with the procedure type itself and more to do with the underlying characteristics of the experience. So we saw that these illnesses varied from discrete medical events to chronic and daily stressors. Perceived traumatic illness-related experiences occurred both in the medical setting and beyond the medical setting, and really across the developmental spectrum, although adolescence appeared to be a very common time. The themes that united the events that were perceived to be traumatic were themes of bodily harm, loss of agency, and shifts in identity. So bodily harm, these are what you may most classically think of, and probably what you thought of when you envisioned a patient in distress. So in a moment when they had perceived life threat or a scary medical experience, but these are not always happening in the medical setting. Now, this patient was a bit older, and so they talked about going to the library to do a paper about cystic fibrosis and having that be the first time that they had learned about the decrease in life expectancy, and is in a moment when there was no support around. In terms of, there were two other very important themes. So loss of agency. People talked about lack of control during medical interaction, which is in no way novel. We know that this is associated with trauma, but they also talked about the feeling that their illness could worsen at any time without warning, that they had no control over that, and that that systems had these elements of care that they were not able to control either. I've put some patient quotes here for you to read on your own. Identity was a particularly important component here. And now we're talking about shifts in the way that someone view themselves. So illness-related experiences that triggered people to change how they viewed themselves were commonly ones that they found to be traumatic. So we see this both when people go from being a well person to a sick person, as you might expect. However, we also see this in the other direction, where patients go from being a sick person to having a life-changing medication available or life-changing surgery available to them. And it's like that surgery still is being traumatic. So this patient says, it feels like I've been trying to survive my whole life. Now I'm on Trikafta, which is a modulator medication for cystic fibrosis. And I'm recognizing like, wow, I no longer have to define myself as a sick person. It's challenging because I don't know who I am outside of that. As I alluded to earlier, the DSM-5 post-traumatic stress symptom domains of intrusion, avoidance, negative mood, and physiologic reactivity were initially developed based on veteran experiences, and they've been expanded on in the increasing recognition of the variation of post-traumatic stress symptoms. Studies on pediatric medical traumatic stress commonly use measures that were developed for these populations. And in this study, we saw that the perceived symptoms of medical traumatic stress could be broadly categorized within the DSM-5 post-traumatic stress symptom domains, but there were important cystic fibrosis and chronic illness-specific manifestations of these symptoms that needed to be considered. So starting with intrusion, we saw largely what one might expect. The stories about flashbacks and scary dreams. Here are some patient quotes for you to read on your own. But as we dove into the other domains, we saw important specific manifestations. In avoidance, we saw treatment dread. So people who in the days and weeks leading into treatment would start to get symptoms of anxiety. In the area of avoidance of care, we heard patients trying literally to run away from their care. This patient says, I would physically try to escape. One time I got into the elevator before they could catch me when they were trying to get me to do blood work, and I just tried to run away. And then we heard about social isolation. And these themes are not altogether new. However, the important thing here is that patients are attributing these symptoms to the traumatic medical events that they've had. In the domain of negative mood, we saw shame, we saw survivor guilt and burden guilt. The related concept of embarrassment to shame has been identified as a key domain in cystic fibrosis related quality of life. And it's been widely identified with patients with traumatic experiences in general. However, this has not been specifically explored within medical traumatic stress. These ideas of survivor guilt and burden guilt, while they're common in the lay land of cystic fibrosis, there's lots of blogs that you can look at about this. In the medical literature, it's really been focused on parents and siblings. We're a bit behind the ball in investigating this. Lastly, in the area of reactivity, we heard about anger, recklessness, germophobia, and these episodes of symptom panic. I'll read this quote because I think it's very powerful and definitely shows how patient symptoms can go on to have important impacts on the moments that we see them in care. So this patient was describing that having a single cough at work, and this is what her thought process was. If my lung is collapsed, am I going to be somewhere where I'm going to be safe? Am I going to be able to get the care that I need? It's going to happen really suddenly this time. It's going to happen in a matter of minutes. Then it's like, who's going to help me get to the hospital? And it was like all these what if scenarios, like playing them out and like what I would react to, what I would do. So you can imagine what it may feel like as a provider on the other end talking to this patient who had had just one cough at work. And that's what we see, that patients and providers both perceive that these symptoms are having an broad ranging functional impairments for patients, and that a component of that I want to focus on today is in health management. So we heard about trouble with adherence, as well as difficulty in provider relationships. Patients saying that they had a lot of self-loathing, guilt, but then once they left the hospital, they would do it all over again, attributing that to their trauma and their symptoms. So summarizing this up, we perceived medical traumatic illness-related events varied from discrete medical events to chronic daily stressors occurring both within the medical care setting and outside of it. In addition to bodily harm, there were these shared themes of loss of agency and shifts in identity. The perceived symptoms of medical traumatic stress could be broadly categorized within the DSM-5 post-traumatic stress symptom domains, but there are important considerations that we need to be thinking about in the evaluation of this in patients with medical traumatic stress. And we also observed a broad range of perceived functional impairments, including illness-specific ramifications on health behaviors and patient-provider relationships. So we've established that medical traumatic stress is happening and that there are some specific considerations that we need. And in some cases, it's profoundly affecting medical care. So where do we go from here? Let's talk a little bit about trauma-informed care. So broadly, we think of trauma-informed care as defined by the Substance Abuse and Mental Health Services Administration, using this quote: a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. We call these the 4 R's. So when we think about trauma-informed medical care of the patient with pediatric onset chronic illness, absolutely, it includes every element of trauma-informed care that has been part of a huge movement through the ACEs Aware movement and others at this institution. However, I would argue that healthcare systems caring for these patients have an additional responsibility due to the potentially traumatic and essential nature of the services that we provide. So we need to resist re-traumatization, and we also need to actively work to prevent primary medical traumatization. We need to screen patients for broad traumas, including adverse childhood experiences like abuse, neglect, household dysfunction, as has been pioneered by Dr. Long here at UCSF and others. But we also need to specifically be looking for symptoms of medical traumatic stress. In our daily practice, we need to recognize the signs and symptoms of medical trauma alongside the other symptoms of trauma that our patients often experience. And we need to have the availability of medical trauma specific treatments as well. So what might this look like? Well, we're fortunate that Ann Kazak, in her work with pediatric oncology patients, developed this model, which is called the Pediatric Psychosocial Preventative Health Model. And she helps us recognize that universally, children and their families are distressed but resilient. There are certain needs that they have, including psychoeducation, where they need to be screened for indicators of high risk and they need support. There is a subset of patients who are at higher risk or a little bit are having acute distress. And those patients need more targeted interventions, including monitoring and specific interventions to address their needs. And then lastly, there's a smaller subset of patients for whom they're having severe, escalating, or persistent effects. And those need access to behavioral health specialists who can really help intensify the psychosocial services that are being offered. So we can imagine what this might look like applying it to our patients with pediatric onset chronic illnesses more broadly. Across all patients, we need aware providers. We need the patients and families to be aware that this is a thing. We need a system that prevents medical trauma, that is systematically assessing risk and screening patients. We need high-risk patients to have access to regular monitoring of their symptoms. We need resources that are specific to their needs to be activated around them. And we need to be monitoring the effect of these symptoms on their overall health and well-being, including components of their medical care and physical health. And then with our patients who are experiencing medical trauma at the highest level, they need specific treatment options. So how do we do this? It requires a systems approach. The system and the individuals orchestrate many of the illness-related experiences that patients with pediatric onset chronic illnesses endure. Patient experience, this is my opinion, the patient experience in chronic illness cannot be left up to the chance of just happening to get a good medical provider who cares about these things. We need a systematic approach. Challenges are broad. There's limited evidence base for the resources that do exist, but I will share some of them with you now. And there's prominent gaps in the resources that exist. They tend to focus on pain, but not the other components of traumatic illness-related experiences. There's a paucity of risk scoring systems, specific screeners for medical trauma and medical trauma diagnostic instruments. And despite similarities between diseases, resources are largely being developed in these disease-specific silos, and that can ultimately stifle progress. So what is out there? There are more resources than this, but I wanted to highlight some key ones that you should be aware of. The National Child Traumatic Stress Network is a fabulous place to start if you're interested in doing in integrating some practices into your life. They have a provider toolkit. CHOP has a Center for Traumatic Stress, which has been incredibly helpful to us at the at the Chronic Illness Center as we think about building a trauma-informed system from the ground up. There's a healthcare toolbox, and the ABP has a roadmap to resilience, emotional health, and mental health. All of these resources foundationally focus on what we call the DEF model, the need to reduce patient distress, provide emotional support, and remember the family. I'm low on time, so I'm not going to go into these in too much detail, but I'm happy to discuss them and give more exhaustive resource lists to folks who would like them. There are also a number of family-facing resources, including a very good video series done by Benioff Children's Hospital, Oakland, that are a series of short, I think about 10-minute videos about medical trauma that's really geared to helping families understand this. The National Child Traumatic Stress Network has a huge plethora of patient resources, including handouts in English and Spanish. Aftertheinjury.org is an interactive site for families, and the Sealy Coping Company has several evidence-based kits for specific diseases. I cannot help but urge you to consider educating your patients and families early and often about medical traumatic stress. Please try not to wait until the patient has undergone several medical traumas and is exhibiting symptoms and functional impairments before implementing these trauma minimizing strategies for medical interactions. UCSF has an amazing child life service, so I just want to plug for them. Use them, they're great. The Meg Foundation for Pain has a lot of family centered resources, including things like this that have fun graphics and can help patients and parents think about how to make encounters more tolerable. Imagine Action is a website developed by Stanford that has some CBT-based resources. And then the Medical Traumatic Stress Network has a number of worksheets for patients and parents to work on together. For those who need treatment, the UCSF Child Research Program has resources, as well as our IP3 team and the Pediatric Psychiatry clinics. I know we are running very short on time, so I'm going to try to do this in 2 minutes. I want to quickly touch base on some recent work that's in progress by myself and one of my mentees, Chris Soufflé. This is a provider survey looking at their medical provider knowledge, practices, and attitudes around medical traumatic stress and illness. And we're wanting to know about their knowledge and practice, but also about their understanding of the resources that exist and what gaps may be there. Here are our aims. So our provider survey, what we're seeing so far, these are early results, is that providers commonly are seeing patients who have pediatric onset chronic illnesses that they suspect have symptoms of medical traumatic stress. And in many cases, these symptoms are leading those providers to want to change the medical care that they provide. And they're observing that the symptoms are impairing the patient's ability or family's ability to pursue their prescribed medical plan. I'm sorry that this is a bit small, but by far and away, providers agree that they play a central role in providing trauma-informed care. But there are marked gaps, both in the ability and the availability and the use of trainings, mental health providers with PMTS experience, and general mental health providers. And when we look at the barriers so far, we're seeing that time and inadequate training and lack of institutional support are significant barriers. So as we go along this path, I'm hoping that we're here and we're going to be moving in this direction towards progress. Some things that are on the horizon are further work investigating the intersection of race-based traumatic stress and medical traumatic stress, which cannot be ignored. The development of chronic illness-specific screening instruments for medical traumatic stress, and the design of scoping systems-level initiatives. I am so thankful, especially to the patients, the families, and the providers who have been entrusting us with their stories and the pursuit of better medical care for children with pediatric onset chronic illnesses. I do want to put in a little plug and encourage you to use this QR code to participate in our provider survey. And I'm incredibly thankful to the committee of both here within UCSF and beyond of incredible mentors who have helped me and guided me down this path. Oops, sorry about that. So at this time, I will take questions, I think. Oh, it looks like, oh, there's.
Thank you. Thank you so much, Dr. Cuneo. There's a number of questions and we're going to see how far we get with them. And some of them are from a little earlier in the talk. There's an attendee who asks, were PTE assessed broadly? In other words, were all potentially inciting events assessed, not just medical events?
Yes, so that is an excellent question. I don't know why this wants to keep moving. I may actually stop my share so that I can look at you guys in the eye. So we asked in that survey just about the 2 items that are on the UCLA PTSD reaction index that refer to medical trauma. So one is, did they have an event that was there a time where they felt that they were so sick that they or their parent thought they may die? And then, so that's the experience of life threat. And then the second one asks about if they ever had a scary medical procedure.
There's another question from someone who says, this was also earlier in the talk, can you clarify negative on ACEs score for the CF group? In patients with chronic illness, an ACE score of 1 or higher is considered high risk, and the category was listed as 0 to 2. So I guess the question is, how did you get to a negative score?
Yeah, we have further analysis to do on that. And I appreciate you bringing that up. There are different people who utilize in their clinics sort of different cutoffs in terms of referring for additional services, et cetera. And so I appreciate you bringing that up. And we do need to reanalyze with the 0 versus 1 or more score.
But I guess the question is, how can you have a negative score if there's...
Oh, if you have none. If you have none, that's what we're...
Dr. Rogers says, wonderful, important talk, Dr. Cuneo. I know we all think of our own fields, but this whole talk is essentially the definition of neonatal critical care. Infants begin their life with trauma, and yet it is required to support their life. And this is often just the beginning of a life of chronic illness. You discuss parental PTSD and trauma. I'm curious if you have come across evidence for how we can better support neonates, and in particular their families, in the trauma that they often carry on behalf of their children, who don't remember the initial trauma, but experience it embedded in their family relationship from the start.
Absolutely. And this is a beautiful and such important question. There is a body of research around medical trauma in neonatal intensive care, and there are people who are looking specifically at this. I'd be very happy to go into some of the specific resources. I would advocate that many of the general resources for medical traumatic stress are pertinent to that population. And I'm happy to share, there's a recent review article that has the information for resources nationally that are available for those who are experiencing medical trauma 5 and under. And so I can get you that if that would be helpful.
I think we're going to squeeze in another question here. Mike Haidt asks, has there been research specifically on the social determinants of health in these traumatic events? And then also says, excellent presentation.
Yeah, so, we do think that the areas that are typically thought of as social determinants of health are overlapping with many of the psychosocial risk factors for medical traumatic stress. And so yes, that has been definitely looked at and investigated.
All right, we're going to do one more. Is there a trauma risk screening tool for families as well?
Yes, so there are some trauma risk screening tools. There's one that is relatively new, and I apologize, our child life folks just started to utilize this one that looks at family risk for medical trauma. And then there's also the psychosocial assessment tool, the pediatric psychosocial assessment tool, it's called the PAT, that was developed at CHOP. And they look at several domains to look at risk for medical trauma.
Thank you very much. We are at time.
Awesome.
Dr. Hirsch, will you close us off? Thank you so much, Dr. Cuneo.
I want to thank Dr. Cuneo for a wonderfully stimulating grand rounds. It was really fabulous, and thank the audience for their participation, and look forward to seeing everyone at the next grand rounds. Have a good rest of your day, everybody.
Thank you all.